Hello, this is just a quick video about Wednesday night, so everyone's welcome to come along. It's 5:30 to 7:30. It might go a little bit late. We're lucky enough to have some clinicians speaking to talk about how they can provide treatment outside of the ACC and medical system domain where might be able to help people with chronic issues. And we'll have people speaking, myself, Greg, and Billy's family. So it should be just a community beginning event to show people that are keen on what the cause is for Billy's Foundation and what we want to try and provide to Nelson. So everyone's welcome. I'm just going to go through 4 key aspects where we want to try and help initially with concussion issues in Nelson. So the first one is if we can help provide a place for people to come and get treatment protocols for recovery and really clear education about what they're experiencing with concussion. So in this acute phase, everyone knows it can be quite a while before you see a GP. So the first 3 weeks are pretty crucial to trying to reduce inflammation and reduce your symptoms. But if you can't get education and you're waiting for a GP or a concussion service, that can slow your recovery down. So that's a key area. We want to try and help facilitate professional care. So through connections with GPs or concussion services, if we can help direct people to the services that are leading and sort of really keen to treat concussion issues in a holistic way. And we want to continue to build community and alliance with other organizations, especially for providing support for family members that don't understand concussion or what their loved one might be experiencing. So I think those 3 things are key for acute injuries and just ensuring people have support and aware of what they're experiencing. So in New Zealand, our diagnosis and treatment for chronic concussion is a little bit vague, where if you get an MRI and you've got physical damage from the scan and that's related to your concussion, you can get ongoing care for longer than 12 months. But if you've had a concussion and you've still got ongoing symptoms, ACC's policy says that the physical metabolic injury is over. Although there is a diagnosis for post-concussion syndrome in other countries, within New Zealand, that diagnosis isn't available in our ACC system. So it just limits people's potential to get treatment. And also if you have chronic issues and you haven't been able to get the treatment to reduce your symptoms, then you're going to get pushed off ACC because of the policy, really. The third part is we want to try and help bring education and awareness around the damages or the dangers of long-term inflammation. So some of the specialists that we've been talking to are saying that the long-term inflammation is a big reason why we're having this degenerative disease issue. So Parkinson's, Alzheimer's, CTE, they could be coming from chronic long-term inflammation. They don't just turn up. So if we can help bring awareness through connections with clinical assessments for potential diagnoses and trying to get the right treatment to stop the chronic ongoing concussion symptoms, that's a real key part that our medical system isn't quite up to speed with compared to the States. The fourth part is just supporting Greg with the Veterans Association. So a really good example of how our safety standards, our medical directives don't equal accurate support treatment or financial support. So last year, the Defence Force Health Director from New Zealand Defence Force Chief Medical Officer Colonel Dr. Charmaine Tate wrote some new safety standards for training to prevent soldiers from getting exposed to blasts too frequently, and it even listed the potential damage, so the symptoms that can arise from being exposed to this blast damage. But with this new safety standards, there's no support or treatment or financial support for the soldiers that have been in the past and have experienced this damage without having these new safety standards. So it's really similar to how there were many people that got injured while having the 7-day turnaround for professional rugby, and the standards were changed to 12 days, but the treatment and I guess the dangers of the players playing with that 7 days hasn't been rectified in a lot of cases. So was the 7-day turnaround too short? It was. They needed to change it, but there's still a lot of damage from that turnaround. So the veteran space is, I guess, something as a country we should be all really keen to help support and bring awareness to our frontline service people. So 4 key areas we want to try and help provide to the community initially. So in New Zealand, if you get a concussion, you'll just go to the GP. You can get referred to a concussion service. There's 6 in Nelson that could take 3 to 6 weeks. The treatment you get is physiotherapist, vestibular rehabilitation, some chiropractor, physical therapy, and occupational therapist, vocational consultants, which is like personal help organizing your daily and weekly routines, and work consultancy to make sure you're organized with work. So with ACC in our medical system, it's quite a passive way of treating concussion. It's just like letting your immune system and natural health try and reduce the inflammation in your brain. It's not a really active, aggressive, multifaceted type holistic treatment that some of the clinicians we're speaking to are trying to provide. There's only a few in New Zealand that are doing it, but there's lots of really cool, innovative medical practitioners overseas that are trying to lead the way with this type of treatment, because if you can get someone recovered and feeling healthy again as soon as possible through an aggressive type of treatment, then they can get back into their lifestyle and avoid the chronic issues. And we're really reliant on neurological assessments and neuropsychiatric assessments with ACC. It's basically to ensure people are having cognitive issues or emotional problems. But like for an example of how we are leaned towards assessments instead of treatment, I've had 9 psychological assessments in 8 years, but I've had very little holistic treatment. All the holistic treatment I've received has been paid and organised through Greg helping me, and finding other resources to try new treatments to come right. So yeah, if you're a moderate TBI injury is only recognised in New Zealand if you've got brain damage from an MRI scan, structural changes, but that's still not always the case, because the young man Zinni from West Coast, he had white matter damage on his brain, which is a physical change structurally, and he wasn't treated for concussion for 2.5 years after his injury, even after getting a scan. And then during that time, he had fatigue, all the common symptoms for concussion. But it is dangerous if we don't get treated for concussion accurately, and if it's linked towards the mental health side of or symptoms of the concussion, then you're not fixing the cause, and that's happening a little bit often. So just a video of a New Zealand rugby employee talking about concussion.
When a player suffers a concussion, they must have a minimum of 21 days before returning to sport, and they must have medical clearance from their GP. We are taking concussion, which is a mild traumatic brain injury, seriously. Concussion is a disturbance of brain function. It is when the brain moves inside the skull. And whilst there's no structural changes to the brain, there are some shearing forces that happen, and it changes the way the brain cells work. So 21 days develops a consistency. And as we've said before, the brain, despite what code you're playing, is exactly the same. If in doubt, sit them out. And that certainly takes.
So I guess the comment he was saying about the structural changes not being apparent with a concussion, I think the structural changes are at a molecular level where the axons are being torn and they're changing potentially the biochemistry, like the pituitary gland and the way it processes our hormones. So I think this is a list from Elizabeth Harris and how she deals with some of the acute and chronic injuries that people experience from concussion. So she just states, to heal the brain, we often need to heal many systems that are out of balance. The main areas are biochemistry, including hormones, with Dr. Mark Gordon from the States. He's leading the veterans support over there. Musculoskeletal issues, functional neurochiropractic, physio, osteo, cervical spine, dural tension, vestibular, rehabilitation from Dr. Mark Allen, which is another concussion rehab facility in the States. Some other treatments that Elizabeth is providing, biophotomodulation, laser and neurotherapy, various practitioners. It's like this low-level light therapy that stimulates, promotes healing and recovery in tissues for pain management, wound healing, and neurological health and athletic recovery. So Elizabeth's working with practitioners from outside of our country to use their protocols to try and maximize this active, holistic treatment process for people to recover quicker, instead of our medical system being more passive and conservative, letting the person heal naturally without any support. But not everyone heals within the normal 1 to 3 month time frame. This was another keynote she shared with us. This is what the blue ones is what the Elizabeth Harris is doing down in Dunedin. Biochemistry, the Mark Gordon protocol to reduce inflammation. This is a protocol that rugby players could take during the season to make sure any concussion issues or just general inflammation build up during the season with the high contact. This type of biochemistry supplementation can help keep the inflammation down. The brain QEEG ERP neurotherapy and TMS is basically these types of treatments trains the brain to improve function by monitoring and altering brainwave patterns. So there's a really cool specialist that we know in Australia, Alan Pearce. He does transcranial magnetic stimulation, and Elizabeth's doing some of these trainings down south. So I've never had this type of therapy. I'm just learning about it, and I'm really keen to try eventually. This is fMRI, Miss Dr. Mark Allen doing biomarkers with functional MRI, which is basically you can get into an MRI machine over there, and it has the ability to assess where the damage is in your brain and then provide a training program to supplement the damage from the MRI. So it's the software that they have in the States for MRI and recognition of what issues somebody's having, but we don't have that technology in New Zealand. I guess this would be another key MRI system for New Zealand rugby to adopt, because you can see clearly with this technology the damage that's been done, where the inflammation is, and then build an idea about how you're going to rehab it. So I'll just chuck up a couple. So how bad is concussion issues in New Zealand? Well, this is off the ACC Reducing Traumatic Brain Injuries, TBI page. A traumatic brain injury, TBI, can happen to anyone at any time, and an estimated 35,000 people in New Zealand suffer from TBIs every year. Of these, 95%, 33,250 are mild TBIs, yet we only received claims of 22,000, or some people don't get their injury checked by a health provider. So concussion is a big issue with our general public. I think in professional sports, it's just the tip of the iceberg. So we want to really try and help support people in the public that, first of all, don't have the access to good education about it or aren't sure where to go. And then hopefully we can help provide the best world-class treatment and help provide financial support, because it won't be covered by ACC, unfortunately. A group that we've been working with the last sort of year since Bill died is the Concussion Legacy Foundation. Helen Murray up in Auckland have been awesome to help educate me and Greg. We went up there a few months ago and we listened to an awesome presentation about what they're achieving at the Auckland University. Anita and Sam, both in the Aussie and American Concussion Legacy Foundation groups, have been awesome supporting us with understanding what they're doing to bring awareness through events, working with other sports like league soccer in Australia, and what they're trying to research to provide biomarkers through scanning machines or blood biomarkers to detect CT earlier than post-death autopsies. A local organisation, the Brain Injury Trust, has been awesome to work with. They helped me out heaps when I was really having issues in 2023. So great people down there. Cindy de Villiers, she's an awesome holistic doctor that's been really helpful for me and Greg with recovery through blood tests and understanding supplement work. This is a functional specialist from Wanaka, Stefan Billing. I just did a 3-month supplement protocol through Stefan's protocol, through Stefan's organization. This is Brain and Health. Elizabeth Harris down in Dunedin. She's been really working hard to try and make change to concussion treatment and bring awareness about different supplements and treatment protocols. If you can just see the different brain health services that she can provide in her clinic in Dunedin. So it's way outside the scope of ACC. And we're lucky enough to speak to Dr. Mark Allen from Cognitive FX a few weeks ago about what they're doing to try and speed up the recovery for people with brain damage through concussion issues. So they put the brain under stress. They train the brain to come in and out of the two autonomic systems, and then try and coax the brain into going back to the state it was before the concussion issue through neuroplasticity training, basically. So I'm just going to chuck a video on the end of this where you can learn about. We're on a short Zoom meeting with Mark Allen from the States, and it was really informative about what sort of treatment they're providing over there, how they deal with NFL, how their relationships are with their medical system and insurance providers. And Elizabeth states how we can try and hopefully through education bring these types of treatment into New Zealand and provide a better health service for Kiwis. So it'd be awesome if you're keen to watch it. I'll chuck it on the end of this video, and also a short video from Dr. Mark Gordon about the biochemistry and reducing inflammation with this neurotropic steroid supplement that, like I said before, it could be really good for professional rugby players or any professional contact sports athletes to use this supplementation to reduce inflammation and prevent long-term degenerative diseases. So it's been really cool to share and get to know people in the public with concussion issues, and to hear people's stories, how they're working through their concussion, how they're managing their concussion, how they deal with their family and work commitments while having concussion. You start building a real good idea around how we might be able to support people and what's the best role we can help with. So we wouldn't be able to understand as much as we have over such a short time frame without getting information and being able to be a part of people's lives that have had concussion problems. So I'm loving meeting new people in this space, and hopefully we can continue working with people that have been injured. I guess that's a big rewarding part for us. So I'll chuck a video on at the end of this if you want to check it out. See you on Wednesday.
Hi, everyone. This is Dr. Mark Gordon of the Millennium Health Centers, Magnolia, Texas. I want to take a little bit of time and review our Phase 2 protocol, which we've been getting a lot of requests for, as well as having over 7,000 people presently on the protocol. What the protocol consists of are 5 products. The 5 products are Brain Rescue 3, DHEA, Brain Care 2, Vitamin D, and pregnenolone. These are the key elements that we have been using now for about 4 years to address people with symptomatology after having traumatic brain injury or chronic stress. The way that the products are used is Brain Rescue 3, 1 packet is taken before breakfast or upon arising. And then at pre-dinner, Brain Care 2 is taken, and that's for 4 weeks only. And then DHEA between 25 and 50 milligrams for males and 15 to 25 milligrams for females, which can be determined by appropriate laboratory testing with your physician. Then pregnenolone is between 30 and 100 milligrams after dinner for males, or 30 to 100 milligrams after dinner for females. Again, your physician taking blood levels will know how best to dose the pregnenolone. And finally, vitamin D. Vitamin D between 125 to 250 micrograms, that's 5,000 to 10,000 international units, to be taken also along with DHA and pregnenolone 15 to 30 minutes after dinner. These all work synergistically together to improve an anti-inflammatory environment in the brain. So how our protocol works is that you use these 5 products for at least 90 days, and then you assess for improvement after that 90-day period of time. If you're at least 50% or better, continue on the program for another 90 days, reassess, and then another 90 days and reassess. The goal is not to be on these products for the rest of your life. Yes, some of them have some keen benefits, but the goal is really not to be on anything if we didn't need it. So the question is, what happens if you're not at least 50% better after a 90-day period of time? What we recommend is you're going and having a 28-point biomarker panel done by us to look for deeper issues of hormonal dysfunction or hormonal dysregulation, which is what we found in a majority of the cases. For those people who do go on or are using the phase 2 protocol, there's a discount code phase 2022 for a 10% discount. Finally, some important links. Our YouTube channel is now growing with lots of the content that I've developed over the past 30 years. Some clips from Joe Rogan, Montel Williams, CBS, NBC, and some of the other projects that I've done over the year are posted, as well as some new videos. Brain Health URL, that is our key educational website, tbihelpnow.org. And then Millennium Products, this is where you can obtain the products at millenniumhealthstore.com. Remember to click off a little box that says you agree to receive emails from us. That's how the code phase 2022 will give you a 10% discount. And finally, if you want to just jump into our protocol, go to tbimedlegal.com and fill out a request form for enrollment in our program, And what'll happen is we'll send you an enrollment application, and then someone will call you as well. All right, thank you very much.
Their brains to be pushed by doing some cardio work, a very specific kind. They get some nice neurochemicals, in place, get a little window where we can really push them on the hardest stuff, and then they go through a rest period, recovery, and then back at it 8 hours a day, several days in a row. And that sustained rehab all day, multiple days in a row, has been a real key to get the brain to take them seriously. It doesn't want to change. It's found this solution that's not a good solution, that locks into, and we coax it to go back to the default way that it has been working for the majority of that person's life. But it takes a lot of coaxing and pushing for it to kind of like, okay, this is a thing. You're not going to let up. I'm not just going to go, retreat back to the same old way. It's got to change. And so those are kind of those are two. So the functional imaging, the intensive cyclical nature of the treatment. And then finally, and we bring in all kinds of great people like Elizabeth, and we eventually convince them to come here. So we've got kind of the best of the best that we've collected and brought here, and they're here under the same roof, all of them working together and coordinating their efforts. So that coordination between, let's say somebody working on vision, somebody working on vestibular, somebody working on the cognitive component, somebody working on other, the physical components, when they are communicating and telling each other what they're doing, they don't interfere, first of all, with each other's therapies.
Yeah, what biomarkers?
Yeah, what biomarkers are you using?
Well, yeah. I mean, the main biomarker assessment is the functional MRI. We do other assessments as well with, in vision, vestibular, cognitive, and so on. It's a very active therapy. So we don't have a lot of passive therapies. We have a few. We use some CO2 treatment, which has been really a wonderful new avenue that we've gone down, and we've started using TMS, but those are really the outliers in terms of passive therapies. The majority of it is active, one-on-one with a therapist, doing, whatever it is, whether it's the cognitive or they're with an occupational therapist or a physical therapist, based on the functional scan and other assessments. They're doing a very individualized kind of rehabilitation with methods that we've found to be the most effective over the years.
And I think I can answer that a little bit more because I understand what you're talking about. What's the actual practicalities? And I was talking with one of the PTs earlier. So basically, it's OTPT, visual therapies. What they're using, though, are techniques that we're not using in New Zealand. So they're using Dynavision, which is a visual board. They're using a Maverick, which is a spatial orientation with lights that people have to touch and move around. They've got a sound localization therapeutic that actually trains the brain to figure out where sound is coming from space. And interestingly, they've had some interesting results where that's returned anosmia, the inability to smell. And then in terms of the physical therapies, what they're doing is much more advanced than what we're doing. Instead of doing a standard VOMS, which is just take a program and set it on everybody and get people to be doing therapy where they're, ending up vomiting at the end of it, they're doing very targeted therapy where they're figuring out the saccule, the utricle, and the three different canals and which are working, which sides are working, much like Louise would do, where it's very kind of gentle and coming in at a bio-individualized level. So they're working with the person. The other thing that they're doing that's quite unique is this periodic exercise. And so they'll get them to exercise for about 30 seconds at high intensity and modulate that using cold therapies and things for them to be able to handle that, and then upregulating BDNF, and then getting the brain to, in that form, because we know there's good research that when the brain is activated, the learning is higher, and then doing these individualized programs, whether it's visual training or auditory or whatever, and then resting them again, and then exercising. So on, off, and just getting the brain, pushing the brain to come out of hibernation, because like Dr. Allen said, often when there's head injury, the brain gets itself into a comfortably uncomfortable position where it is just kind of surviving on the low energy. It's a bit like people who stay at home all day and eat, junk food and watch videos. They feel pretty crappy. And if you said to them they had to go and exercise, they'd say they couldn't do it. But once they start doing it, they actually feel better.
That's right. And, so we've got this autonomic layer on top that, so everybody has these individual dysfunctions, cognitive, very specific, visual deficits, vestibular deficits, and we pay attention to. It's important to rehabilitate one side and not the other. When but on top of that, they almost all have this ANS dysregulation. Almost everybody who comes here has this overactive sympathetic drive, and that's something that globally we address as we repair the different burdens on the brain from these dysfunctions. That alleviates some of that autonomic dysfunction. The brain isn't as you're getting good processing, you're getting good inputs, good sensory, good cognitive processing. That lowers that ANS kind of brain being terrified all the time. But then there is a more fundamental physiological level of autonomic dysfunction that almost every patient has, that we address with these physical, a special kind of cardio that takes people through the full range of exercise, from rest to extreme exertion back down to extreme rest in a very short time period, which is kind of engaging the two chains of the autonomic system over and over, kind of letting them fight it out, getting familiar again with that balance that they, we kind of force them to fight, and the parasympathetic starts to exert its will again and become stronger and
the brain loves a habit, doesn't it? It loves a good habit. And so when you're talking about hormone therapy, you're referring to the promotion of endogenous hormones through, I guess, Elizabeth, what's accessible to us in New Zealand is like using the CO2 therapy through, say, cold water plunging to increase those cold shock proteins that enhances that immune function and anti-inflammatory function. So I'm just trying to work out what's accessible to us here in New Zealand. Yeah. And then when you're looking at the BDNF, increasing of the BDNF and other genetic proteins, I guess, like metallothionein genes and things like that, which we know are anti-inflammatory, you can use that through your intensive cardio exercise. And I guess I'm curious from a naturopathic perspective, what like we could go in with some herbals as well to increase BDNF. Because I guess
Exactly.
Shane's local to us, you see, so we're just wondering how we can support Shane here locally. Yeah.
Yeah, exactly. And that's why, I'm interested in Elizabeth and, the Mark Gordon kind of side of things is that, we don't really get much into the actual manipulating, people, what people are taking in to regulate hormones and other, neurochemicals and the kinds of things that you all are experts in. We're, actually not really strong in that. We partly, we have our formula, it's successful. And so we, but also that we do things in a week or 2 weeks. And so things that take longer, like let's say biomodulation, those kinds of therapies that take, like might take a month or longer, and other kinds of neurotherapies that are more long running, we're not really able to implement. We could, start patients off on that or have them doing something prior to coming here to get them in better condition to handle these therapies. But we're not, administering much of that ourselves at all.
I think also in answer to that, I think talking with Shane and Pup and Louise and I and Rebecca, we're all very keen to see a centre of excellence in New Zealand, from which training and protocols and things like that for the smaller centres that are doable in smaller centres. I think we could definitely develop something such that, we hopefully aiming for 70-80% response in the smaller centres, and then if people didn't respond, there's a larger centre that they can go to. But I guess, talking with the guys here, whether they're interested in expanding to New Zealand in one form or another. But I think, and we were also talking, Shane and I, about New Zealand is very unique, I believe, in that it's very small, and just like the 2 Degrees, phone company, we're all pretty close to somebody of influence. And I think there's the ability to completely change the face of concussion management in New Zealand and be able to prove that and show that as a model for the rest of the world. And we've got to sit down and figure out what does that look like. How, and as a GP and a rural GP, I'm really passionate about everybody being able to receive help. And so how do we design things so that we can reach everybody at all different levels? And I think going forward, we're going to have a lot of conversations. And those conversations involve, firstly, hearing what other people are doing and how they're doing it, looking at what's available to us, like you said, and then how we're going to incorporate that. And do we have a training program that we run in New Zealand that incorporates this sort of level of rehab and have access to functional MRI for those that we want to be able to do diagnostic studies on? So there's lots of conversations to come yet, and this is really just the beginning. But here's the areas that other people are working on in the world. The areas in green are the areas that I think that the guys here are working on. So they're working on the biomarkers with fMRI, and there's another biomarker, which is ERP, that could be put in the rehab, including vestibular. Then there's this biochemical stuff, and this is not representational. I was thinking about this, the size of the circles. These guys, their circles need to be really big, and in blue is what I'm doing, and it needs to be really small because I'm very small and not doing near as much as these guys are doing. But so what you're talking about, Rebecca, is the biochemistry, and specifically Mark Gordon, and this is not the stuff that Dr. Mark Allen is doing. And note, with the results that he's getting, if they're getting like a 90% improvement and whatever it was, 70-80% a complete restoration doing this, and then Mark Gordon is getting the results that he's getting, I think where we're angling to go. And then there's the whole cervical dural tension work that Louise is doing as well, and the guys here are now putting in TMS as well, transcranial magnetic stim. So that's why I've got that in green, and it's part of actual direct brain therapy. I think that there's the possibility to put together a unit that has all of the areas that people are working on and getting really great results. And so any questions that you've got for Dr. Allen would be in the green.
Yeah.
Okay.
But I see the role. So we were doing blood testing, but not with the sophistication that Elizabeth does or Mark Gordon and well, LabCorp that we were using raised their price by like 1,000% or something. It was like 150 per patient. Now it's like 800 something. Anyway, so
I think I paid 800.
Yeah.
But I see the biochemistry as more effective preliminary prior to coming. So you have this all. Okay. So if you have all that regulated and in place, our therapies will be more efficient. Yeah. Now, what we were doing some blood testing and some basic hormone stuff, pituitary and so on, and kind of sending people home with that report and saying, now get this addressed, with your GP and or a neuroendocrinology specialist or so, whatever, kind of leaving it up to them, not something that we were doing. But I would really see it more effective as being something. If people were on solid ground there, then we could really go to work with them here.
Season. Our biggest issue at the moment in New Zealand, and Shane will attest to this, is we have a standard protocol if you're not professional to return to play in 3 weeks, but that's only on how you feel. There's no objective measure. But for professional players like Shane was, it's 2 weeks.
Yeah.
That could be done?
Well, yeah, and we did. So we started out with the NFL, the National Football League, with the New England Patriots, to be specific. That's where we worked out this whole protocol is with Tom Brady. And it's just there's so much control and jealousy among the medical staff of each of those teams. They don't like some outsider knowing more, doing something for their players where they're supposed to be the gods of medicine for that team. And so it's a mess. So we've had NFL individual players come to us, their agents who, secretly get them here. But yeah, so it's really difficult to work with when there's a lot of money involved in a professional sport.
And it may be different in New Zealand, but here in America, like Dr. Allen said, the players don't want their team to know they're injured at all. So, they'll give us a fake name and pay in cash. So if we ever did get hacked or anything else, their name doesn't show up and, they'll, we'd have to schedule it so they're in one part of the clinic so no one can take a picture of them. It gets complicated and there's, the players don't, they want to play. They don't want to be known as the head injury guy that's not going to get a contract next time. So it's a lot of interesting pieces whenever we get a professional athlete coming through.
Yeah, and also what's important to note, when I went to Meta, I was talking with some of the researchers there, and there was a research study undertaken in New Zealand where they funneled people who had a head injury immediately into a concussion service, whereas usually now in New Zealand it's sort of 3 weeks or longer. And what they showed very conclusively was that immediate referral to a concussion service resulted in a very significant reduction in those who went on to post-concussion syndrome. Apparently they took that to the study from AUT to ACC, and the lower echelons, they were really keen. But when it got to the upper echelons, they culled it. And I guess it was because they looked at the number of people who would need to be accessing a concussion service and felt that that wasn't, going to be cost effective, whereas it probably actually would. But I think the NAC is even more cost effective because I can imagine in bulk, it might be $30, $40 per person, which compared to, it's between $3,000 and $5,000, my understanding, is the amount that's attributed to a patient as soon as they've entered the ACC concussion service. But yeah, and talking about it, is there anything that can be done immediately? Yes. Being referred immediately to a really adequate concussion service? Yes. And we're not doing it, and we know about it, and we're not doing it.
Yeah.
And also this idea of return to play after 2 2 weeks. The research is very clear. There's a guy, Marshall, who runs concussion management, and he's really great. He, gives access to a lot of research and protocols and things like that. And reading through the material that he had provided, it's very clear that, there's kind of this month mark where you really don't want to get another head injury, even if you're asymptomatic. Otherwise, there's this ongoing roll-on effect of the M1, I think it's M1, microglial activation that occurs in the brain, and ongoing cytokine and neuroinflammation.
Yeah.